Hi, this is Dr. David Schneider. I'd like to explain how we do our preoperative templating, our planning, when we're thinking about doing a total shoulder. I'm sitting here in my office tonight, actually doing my templating, and I thought, you know what? Instead of getting dressed in my fancy duds, I'm here in my sweatshirt. I'd like to show you how it actually works. We use what's called Signature 2.0. It's the advanced software package from Zimmer Biomet that helps us exactly decide the placement and the size of the implants we're going to use when we do a total shoulder. You know, more and more, we're doing more and more challenging cases. Shoulders we wouldn't have dreamed of addressing even 5 or 10 years ago. When I was a resident, it was this incredible day of honor when you were actually entrusted with these big plastic overlays. This is a Zimmer total hip, but the plastic sheets all had different sizes of the implants, and you could lay it over the physical x-ray, because again, when I was in residency, we didn't have digital x-rays yet, at least not in the first part of my residency at Penn State. So we'd have these big plastic sheets that we'd lay over the x-ray and try and decide what size total hip to place. And you can see we've taken this size 12 on the right side, laid it over the x-ray of the hip, and there's even a little notch where we actually draw on the x-ray itself. So we had these red China markers, kind of waxy pencils, almost like a crayon, and we draw and notate the sizes of the implants that we were predicting we would use. We thought that was pretty sophisticated, and of course now no one does anything like that. We do it with segmented CT scans. So we get a preoperative CT scan, has to be a very specialized, very high quality, thin cut CT scan, and that allows us then to develop a three-dimensional representation of the patient's shoulder. So I'm going to walk you through how we actually template. So both these patients, it's a right shoulder for a standard total shoulder and then a reverse total shoulder. Both happen to be college football players of some note. This patient, I can now turn on, I can spin this around and look at the three-dimensional architecture of the patient. I can make the shoulder blade go away and just look at the humerus. And again, we have all these predetermined centers of rotation and orientation, so we know exactly case after case where we're going to plan. This red plane is the so-called anatomical plane of the total shoulder. That's where the humeral head sits. This green plane is where we're actually going to make the cut. I can then place the implant. In this case, I'm going to use a stemless implant, but as a backup, we plan it so that that blue stem, in case I need to use a little small stem, we can put it there. I can then make the bone cut, and I can think about where I want that humeral head to sit. You can see by placing both on the computer, making it blue, you can see it just poking out from underneath the bony surface. And if I make it bigger and bigger, it'll actually be too big. I can also then change the so-called eccentricity of the implant. I can make it so that it's not perfectly centered and allows me to spin it around to get greater coverage. What we're trying to reproduce is trying to get the replaced metallic humeral head basically where the old humeral head was. And I always tell patients, based upon your philosophical outlook, it's either where Mother Nature had it or where Father God had it. And you can see I'm raising it a little bit here, raising it again, just nudging it to where it's actually protruding. And I would actually say, now it's too high. So I'm going to back it off a little bit because I don't want it being too big, or what we call overstuffed, because if it's too big, it's going to impinge against your own rotator cuff and in time cause a rotator cuff tear. That used to be one of the big reasons that patients' total shoulders would fail. The surgeon would put it in too high, or he'd use an implant that was too big, and it would start pinching up against the rotator cuff tendon, which would then cause a tear, and then the patient wouldn't be able to raise their shoulder anymore. I can look at my cut planes again. I can make sure that this ball is going to perfectly cover the original cut surface. Now, I'm toying around again with this. I want you to see how the thought process goes. I'm going to change the eccentricity again, see if I can spin it around, see if that changes the coverage. I want it to be a little bit more over there because I didn't want it to overhang too much and hurt one of the rotator cuff tendons. So again, I'm really, we're at this point where we're down to that 1 millimeter of thinking, is it too big? We don't mind if it's a little big down below. There's no rotator cuff attachment there. But I'm looking at that eccentricity. I can spin it around, or I can decide maybe it's actually just a whisker too big. Or maybe I can lower it a little bit. See, I'm actually moving the stem over. I'm lowering the implant again. And then I can bring the bone back. Put it in movie mode and I can move it around. Now we're getting really good because it's not touching the top of the rotator cuff tendons where they're inserting on the top of that bone. We're getting really close to feeling like this is going to be a perfectly placed shoulder. And again, I can decrease the size a little bit. So I just decreased it down 4 millimeters. And we don't mind if it's a couple millimeters too small. That's actually pretty ideal. I can spin it around and make sure that I'm not touching into the rotator cuff tendons because we want this to be a very, very long-lasting total shoulder. I can trim away some of that bone front and back. We'll get all the bone spurs out of the way. We're nearing perfection there. That's actually looking really good. Now we go to the scapula. Now, when we do a total shoulder, we resurface the shoulder socket side. I can move it around. We're using a special wedged implant here. We got 100% surface. That's ideal. Here's one of the magic moments. I can dynamize this. I can make sure that it moves perfectly, that the patient has full range of motion, no impingement, that it's perfectly centered. And we would say, bingo, that's what I want. And we give this video to the patient either the night before surgery or right before surgery. I do an airdrop, or I email the family. Everyone who wants it can have a video of this, and we tell them this is what your x-ray is going to look like. So the next patient, this is another former college football player, great big man, still very powerful gentleman, aged in his early 60s. And he has arthritis, but he also has a massive rotator cuff tear. He can hardly use his arm at all. So again, I made it so I not made all the changes because I want you to be able to see kind of what we think through. Here's the humeral ball. I can make the implant go away. I can spin around and look at all the bone spurs, and it can let me think about what I'm going to take out. I can make the bone see-through. I can put the implant back in. And I can think about, is it perfectly down? And we just use these little micro stems. I can lower that cut. You can see I'm lowering the implant. That red cut plane is the so-called anatomic cut plane. I'm going to lower it down a little bit. This is that green cut plane. I'm lowering it down several millimeters more. And as I do that, you can see it kind of touches into the bone. That little red area shows that it's a little too big, so I decreased it down 1. Now it's a 17 millimeter stem, which still is huge, but again, this is a very large, powerful gentleman. I can look at it and say that is looking really, really good. It's right down the pike. It's angled perfectly and it's sitting perfectly. But I'm going to change it to a 40. That was a 40 bearing. We want to make sure that this is the biggest tray possible because we're going to use the largest ball possible as well. So the first change I'm going to make, I'm going to change the so-called glenosphere, the ball that's on the shoulder socket side. We're going to make that the largest possible, which still on this gentleman looks small. A 40 millimeter on an average size female patient would look gargantuan, but in this patient it's perfect. Now I can think about where the base plate is. It's a touch low there, so I want to raise it a little bit. I can raise it with this tool that allows me to click, 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 go up a little bit. And I want it to be about almost 100% of the ream surface. So 87 is not quite good enough. I can lower it a teeny bit 95. How else can I do it? Well, I can choose a larger wedge. So now it's a medium-sized wedge, and I want to make sure that it's tilted, and this is 5 degrees of inclination. You can see there. Won't explain everything we think through here, but I can move the implant around, and now it's 99% ream surface by using that medium-sized augment. And I can move it around, and now it's getting perfect. We've got this perfectly placed implant. We want the screw coming out just a whisker there deeply. It makes it really, really strong and stable, especially for a guy that's going to go back to working out with his shoulder. And again, I can change the eccentricity here. I can spin the ball around. I can lower it a little bit. I want clearance underneath there so that it can move. And so when I was planning this, I was thinking, man, it needs to be a teeny bit better. I'm going to lower this implant down just a whisker. Going to get the correct tool so I can lower it down. And then once I get it exactly in the spot I want, it's 96% ream surface, which is great. Now I can look at it from the front. Again, this is the right shoulder. Now it's perfect, right where I'm pointing with that arrow. That is going to allow the patient to move his shoulder around, and I can dynamize it again and bring it through full range of motion. Moves to the front, it moves to the back. It's not hitting anything. Full abduction. This guy's going to be able to raise his arm all the way up and go back to working out. He gets to go to his exercise classes with his wife again because his arm is going to function again. So that's how we plan a reverse shoulder. So the fun thing is we send the images, again, before surgery. We tell them, this is what your x-ray is going to look like. And then this is what it is. And we can measure it out. We wanted that angle to be 45 degrees. And when we measure it with our other templating software, it actually is perfectly 45 degrees. Even just 5 years ago, we could have never dreamed of this type of accuracy. And of course, it's accuracy that correlates with outcomes. That's what every patient wants. They want to have one operation and have a shoulder that works fantastically well. And we're able to do that in part because we can do all the preoperative computer templating, but we're interfacing with the ROSA robot. I'm part of the design team, and in late April of 2024, I got to be the first surgeon in the world to do a robotically assisted primary total shoulder. And my colleagues and I from the Mayo Clinic and other very prestigious facilities have been at this for about 4 years, working on cadavers, but just in 2024 we're using it. So you can see the implant. I left the volume on so you can see the chiming. This is what we do ahead of time. People think when we say robot, are we talking about a lost in space kind of a Jimmy Neutron thing? No, this is this mechanical arm that can bend and twist. We've done all the computer templating, but this allows us, we're just doing what's called the registration with that fake shoulder that's there. But once we're at the time of surgery, we'll have a surgical guide on there, which will then guide us into knowing exactly where we want to put it. And this is kind of the miracle of robotics. We can use the computer templating software to know exactly where we want to be. Then we can use the robotics to guide us, and we're down to the 1 millimeter or 1 degree level of precision when we're doing total shoulders. One of my favorite quotes is from Maya Angelou. People will forget what you said, people will forget what you did, but people will never forget how you made them feel. And that's the incredible thing about being a joint replacement shoulder surgeon, and that we're able to help people feel better and do more. And we're able to accomplish that by using good old fancy computers and robots combined with, I've been very fortunate to have years of surgical experience and done thousands of total shoulders, but it's never been better by embracing technology. Hope you enjoyed it.